So moving right along, if you watch and follow our agenda, we have a wonderful customer success story coming to you today with me, your hostess, from Riverside Regional Medical Center. Our guest today is Angel Castaneda. I'm going to butcher your name, Angel, so I'm so sorry. She's a nurse manager at Riverside Regional of the float pool, and Angel is an accomplished nursing leader with over 10 years experience in the field. Since 2017, Angel has held her current role, where she has demonstrated strong analytical skills, team building abilities, and the proven track record of achieving goals in patient safety and satisfaction. Outside of her nursing role, Angel is a busy mom, sports mom at that, and a wife of a firefighter. So we have two wonderful first responders in that family. So exciting. Welcome to the program, Angel.
Thank you. Thank you very much. It's nice to be here.
So let's get started with talking a little bit about your program. Tell us a little bit about your program, and included in that, let's hear about your patient population that you're monitoring.
So we started our program November 2021. It just seemed the right time for our health system to begin this program. We were seeing a high volume of sitter cases, especially with COVID coming about in the psych area, just plummeting and needing more help. So we found AvaSure, very grateful for AvaSure. And our patient population, we were able to focus more on our patients who need occasional reminding, but not that constant reminding, in order to keep them safe. We are a very high acuity level 2 trauma center. So this just helps us further keep our patients safe and keep our dollars in.
Wonderful. So when you started your program during COVID in 2021, tell us a little bit about how you made your selection from your devices and to how to build your program. Tell us a little bit about the infrastructure of your program.
So we actually had looked at this program several years ago, myself and my current CNO, and it just wasn't the right time. And then it was brought up again. So we set this up to do the 12 monitoring system by one CNA, our telemonitor person is the CNA. And if we were able to develop the policy and partner with AvaSure, they have a great program as far as directing everybody on how to implement this program and make it fit their hospital. Because not one shoe doesn't fit everybody, right? So they've really helped us develop this program to make it work for our health system.
So how many devices do you have currently at your organization?
We currently have 12. Okay. There are, for us to monitor one of our sister hospitals, up to 4 of theirs, but we still only monitor up to 12 patients at a time. But on days that we only had 10, we can monitor 2 of theirs, and we kind of help share in that those duties.
Very nice. So talking about your patient population, my understanding is that you've done a lot of work being able to transition your patients from Riverside Regional into a SNF or an LTAC. Can you tell us a little bit about what you guys did? Because I ask this because oftentimes organizations are struggling to get their patients discharged and moved over because they needed a sitter. So can you talk to us a little bit about what you did that allowed you to go ahead and make those transitions?
So we're not unlike any other hospital. We did have that challenge, but implementing AvaSure, we were able to partner with local SNF, especially our own, and AvaSure actually helped us with a letter, and we were able to alter it to our own to kind of explain what the device was and that it was not a shoe spitter. We were also able to heavily educate care managers about how to document what they should be documenting, and just give them that education that this is not an in-person center. This should not delay transfer of care, and that helped us significantly. The care managers appreciate it. We still do occasional education with the case managers just to make sure everybody's on the same page and we can get our patients the care they need.
Wonderful. So you bring up a good point about education. So it sounds to me that you're not only educating the caregivers that are using the solution, right? You're also educating multiple different disciplines within the organization. Can you tell me a little bit about how you go about educating? Is it in person? Is it an LMS module? Just so everybody, because this again comes up quite often, is once we deploy, when you deployed in 2021, everybody was well educated. We had educators on site. How do you facilitate that ongoing education to make sure that your program stays successful?
So we took a lot of the modules that AvaSure provided and turned them to annual e-learning. So everybody gets it upon hire, and then of course annually. And then we also add another layer where when someone comes down to get the device, our patient safety monitor tech tells them what to do, how to do it, how to clean the device. It kind of pretty much goes from the whole process, plugging it in, turns it on, privacy mode. They just go over everything just to kind of revisit that information with that particular person who's going to be caring for that patient.
Perfect. So kind of like Aurora in the last, I'm sure somebody's going to ask, since you have 12 devices, that's pretty much your max of what you're going to be monitoring at any given time, correct? Tell me a little bit about, I think to put some context around it, tell me a little bit about Riverside Regional, how many beds you are, about your sister hospitals that you're monitoring, just so that those folks that are watching this program and they're trying to think about how they're going to get on this journey, how you came to the conclusion to go with 12 devices when relative ratios to your bed count.
So we are about 400, I say 450, but that's busting at the seams. Level 2 trauma center, and we averaged about 8 sitter cases a day pre-COVID. So we kind of use that information to kind of decide how many devices and where we would start. And we also did not include suicide in our initial rollout of this. Initially, it was kind of hard to get people to come on board because they were used to that in person. So we went round one by one and kind of helped educate staff and made them feel more comfortable. And now it's just taken off. We do monitor our utilization if we get to a point to where we have to decide we have no devices left, but this other person really needs to. That's when our supervisors really step in and they evaluate our in-person cases and our remote cases to see who they can triage on and off, or do we need to start a week. But luckily, knock on wood, we have not had a quote-unquote waiting list. Our supervisors have done a great job about triaging the patient continues.
Very nice. So you kind of alluded to it about some challenges in the beginning. Help me understand, and everybody watching, how you overcome some of those challenges, especially because I know with nursing, oftentimes when we do have that one-to-one sitter, they become reliant upon them, right? They help with doing the daily care. They become obviously a part of the care team, but also in that direct care of that patient. So help me understand how you were able to overcome that obstacle. And with your utilization as high as it is, you obviously have done an amazing job making sure that staff feel comfortable and safe using it.
So initially, at the beginning, the first rollout date, we looked at all of our sitter cases and I prioritized them who would be best to switch to AvaSure. And we talked to our sitters that were in there, because if they're telling me this patient doesn't really do anything, they just need occasional reminding, okay, that's a great candidate to start with to show people that this really does work. And then we also, for staff who are really resistant, the fall risk patients are the ones that, they're terrified to get a fall, and I completely understand that. We would have like a phased attempt where we would have an AvaSure device in the room, but then we would have a sitter outside the room. So that way, if there was an issue, they could respond very quickly versus the nurse who may be in another patient's room. So we really just went one by one and educated that nurse and that charge nurse and that aide on that floor. And it was through that we were able to kind of say, okay, well, since this nurse trusted, maybe they'll be able to tell the next nurse, yeah, trusted, it works great. And it's just caught fire like that. So it's done really well.
Perfect. So kind of digging into your program a little bit more, help me understand some of your workflows behind it. So for instance, if your telesitter sees something and they want to communicate with the bedside caregivers, tell us, I want to make sure that everybody who is new to AvaSure, who's not familiar with the process and trying to wrap their brains around how you deploy a solution like this. How did you get your telesitters able to communicate with your bedside caregivers and build that trust and just have those interactions?
So on every device, we actually put the telemonitor room's phone number. So that way they could easily have a quick contact. We also made sure that if there's an issue, you kind of have to assess, is this something that I need to get somebody there now or just kind of warn them about? So the monitor tech will call up to the unit. They know which nurse, what unit, what phone number to call. They'll call up to the unit and say, hey, the patient's doing this, or they need a bed can, or they're asking to call their mother or something like that. And then, of course, there's the prompts and then the stat alarm, which is a great feature. I love the stat alarm. So if it's something really urgent, we can get staff there quickly. And I'm very proud to say we have pretty much stayed under the target goal.
So can you share a little bit about your target goal and some of your outcomes that you've seen already?
So we've stayed around 12 to 15, depending on our volume, for 12 to 15 seconds for our response time. And that's just through education and education. I can't say that enough. But working with staff and letting them know that when we hit this alarm, that means we don't have time for somebody sitting to the phone. We need staff to come now. Whether it's an aide, a nurse, somebody just needs to get there quickly. And it's kind of amazing to be on the units because when a stat alarm goes off, you can really hear it. And staff really do come flying down the halls to make sure that everything's okay.
Perfect. And for those folks that aren't familiar with that, with AvaSure, the telesitter has a capability to obviously interact with the patient, talk to them, redirect them. But in the event that they're in imminent danger, or maybe they're faster than what we think they are, they're able to pop out of bed and try to get out of bed quickly, that telesitter has the capability to go ahead and trigger what we call a stat alarm. To Angel's point, it alarms at the device level. So unlike your bed exit alarms, where a lot of folks are experiencing some alarm fatigue from that because they get a lot of false bed exit alarms, this is a human validated alarm. So to Angel's point with the education, training the staff to understand that somebody is physically watching this patient, sees that they're in imminent danger, and they need to trigger that alarm because they need to get staff in there really quickly. Angel's response time is stellar. It's amazing. With 12 to 15 seconds is really amazing. National average we see is about 17 seconds. And going back to Angel's point about education, part of the education to get that true metric is that, I'm sure Angel will attest to this, is that you train your staff that when you trigger that alarm, even if the patient sits back down in bed, you still leave it as an audible tone because there was a reason they're trying to get out of bed. And our number one goal in healthcare, and everybody can agree that's watching this program, is to keep our patients safe. So it doesn't do us any good if we trigger that alarm and then stop it when that patient lays back down, because guess what? They're going to want to get back up again because there's a reason they're trying to get out of bed, or if they're trying to elope, or whatever the case may be. So I love that you are really kind of pointing out the need for education and ongoing education. I know your program started in 2021. What are you doing with your new staff coming on for onboarding and any kind of continuing education for your program? That would be very helpful for people to understand.
So there is e-learning modules, not only for people who are onboarding, but annual e-learning modules. It's presented at our skills fair that's held, I think we do it 4 or 5 times a year. So that's really helped push education. And then we always do the one-on-one education. So if we have a particular opportunity with the unit, we use that time to educate and talk with the manager, and we could go to staff meetings or just do that one-on-one education if it's an individualized issue.
Great. So the other component that I think is really compelling from your program is you did implement the Gatekeeper program, correct?
In a way, yes.
So tell, again, I think what's really beneficial to you and your segment is just kind of getting people to understand how you start a program, how you maintain it. So I know in a way you started that Gatekeeper. Can you elaborate on what your vision was for that?
Everything kind of fell into place. I will say AvaSure is very good at helping people roll out this program and helping us fit our needs. So we already had a supervisor in place that normally around consider cases, and then we have our staff that monitor, and then we have our staffers. So our staffers help when people call down and say, do you they need a device? Okay, yes, we have one available, or no, we do not. We'll send the supervisor to evaluate. And a lot of times the monitor tech too will give feedback. Hey, I think this patient could potentially be ready to come off of this device, or this patient's not a candidate for a remote device. And the supervisor, they're right here in the same office, and they partner with that on every patient.
Perfect. So we did get some questions from our audience, and I'm not surprised by them because I think it's really a hot topic, especially for those organizations that are current AvaSure users. So the one question is, we're getting resistance from the SNFs in accepting patients. Besides letter and educating staff, what are other options that we can take or methods that we can use to make sure that they understand that they can accept these patients?
So what we found was it was really in the documentation of the case. It was how they were wording what this device was, eliminating that verbiage of sitter, eliminating that verbiage of continuous monitoring is what we found worked best, because that's what they're focused on. And 9 times out of 10, it's not a phone call that you're making to another place. You're submitting information into a data system, and they're popping it back out whether the accepted patient, and they're reading our notes. So it's all about how you're documenting it. And, you know, we're not trying to pull the wool over anybody's eyes. It's just truly that this is a device that works the same as if somebody were walking around the hall. They're just checking on the patient, seeing how they're doing. So it is just about the wording in that documentation. That's what really sealed the deal for us, in addition to the other.
So did you go out then too and educate the SNFs and the LTACs that you closely worked with and talk to them and explain to them, or even invite them over to see your program? I'm not sure if you did, but I just think it'd be an interesting way to introduce them to it.
So they're for the Riverside owned system, yes. I went to one of their meetings and discussed it with their leaders and their admission coordinators, things like that. So they were able to ask questions and see a demo. And then we partnered with another facility, the rehab hospital. They came over and they looked at it and they were like, oh, okay, this makes sense now. So it's very helpful for them to see it and for them to meet with their department that's running it.
Yeah. And, you know, to me, we do have an LTAC session later today talking about how they're using it. I think this is a wonderful opportunity for us to share this knowledge with SNFs and LTACs, because they're struggling too, right? You need to get patients out, and if they can't take a patient, then you're compromising their flow, because then they need to work at capacity. So I think the session later on this afternoon will be really compelling to kind of build this case, because it can be used not only in acute care setting, it can also be used in SNFs and LTACs. We have multiple rehab facilities that are using AvaSure today, and they're really showing powerful outcomes. But to your point, being able to move your patients out, especially when we're so compromised with staff and we need to get those bed spaces and contribute to throughput, there's no reason why we can't move them over to those SNFs or LTACs, especially like you said, you've built out that program and made it clear to them. The other question, oh, go ahead. I'm sorry, Angel.
It's all about partnership.
Yes, 100%. Partnership is key. I think it's probably easier, like to your point, when you are talking to one that's part of your system, it's probably easier for them to get buy-in. But for those that are not, it's just exactly to your point, partnership, talking to them about the impact, and maybe we can introduce them via these seminars and let them see that the benefits of using it in their facility as well. It's not out of the realm of possibility. Yeah. So the other question is, and you kind of alluded to it, about the verbiage that you're using in your documentation. What other components? Obviously, you said we don't want to talk about continuous monitoring in your documentation. So case managers are doing that. What about from a nursing perspective? What kind of tidbits can you give about nursing in their documentation, or to help leverage them get over to those SNFs?
So within our policies, we have what you're supposed to document every 4 hours. And within that, we use Epic, one of the more known EMR systems, that they're able to document what type of device is being used. Is it in person? Is it somebody hired from the family? Is it the remote patient monitoring device? And then why? So they're able to see that documentation as well. And with that, again, with that partnering with the education, knowing what that means when we mark it as a remote patient. So the nurses really don't have to make a note unless something substantial happens. They're able to chart right there within their flow sheet what type of sitter device is being used, whether in person or other.
So do your telesitters document in Epic?
They do not.
Okay, so what about, do they use the AvaSure software? And like Elizabeth said earlier, they can go ahead and document events that happen, right? Are they doing any of that, or are they doing it? Because some of these organizations that I visit, they are still using paper, let's be honest. But what about your organization? How are they capturing some of that information?
So a lot of it is all through the system. The thing I love about our system is that everything we do in the system is recorded. Obviously not the video stream, but the alerts and the prompts and the events. And I actually have our dashboard set up so I get an email for a certain type of event. And then I forward that on to that manager, which has been helpful because they place what we call RCare, which is an internal process review of an event, and they're able to get that additional information real time. What happened? What did the patient safety monitors had see? What did they do? And then did we continue monitoring the patient?
Very nice. So my other question to you, and I have a smattering of questions, so thank you very much for your patience and openness to answer these. We talked about, Aurora talked about good catches and sharing information. How do you disseminate if you do have an event and you want to share it with the staff to show that this solution is working for you? Do you guys do anything special for good catches, or?
Yeah, so we have two ways to kind of do that. One way is during our morning huddles with all of leadership, we bring that up if it's a good catch. I have one of my favorite stories that I'll share in just a minute. But another thing that I did just to kind of promote the program was I purchased an award.
Oh.
And so the unit who gets the safety, gets the safety care unit once they get this to hold on their unit. And then they also get a certificate. I send an email out to all of leadership showing, this is the patient care safety care unit of the month. This is how many hours were monitored. This is how many events were prevented. Just to kind of make it a little bit of a competition, healthy competition. And it's kind of taken off. It's kind of quite funny because people are like, well, we had one unit who got it several months in a row, and one of the other leaders said, well, what's your secret? How do you do this? And she's like, well, I can't let you know my secret because she wanted to keep the award. Yes. So that kind of put forth a lot of healthy competition between the units to make sure that they're using the device appropriately and as often as possible.
So, and that same vein of the units, tell everybody listening, because I do get some pushback when I go and I talk to organizations that they say, well, we don't really want to use it in the ED. We don't really want to use it in the ICU. We're just focusing on 1 or 2 med-surg units. Tell everybody listening what type of units and how many units and how you guys are using it today across the spectrum.
So we currently use it only on the inpatient side. The ED is one of the phases that we're going to phase in the future. We wanted to start out slow and get people used to the idea and buy in the idea. And then we had to deal with COVID on top of that. But we use this across all of our units. We have medical ICU, surgical ICUs, oncology ICU. We have labor and delivery, women and infants, several medical units, several surgical units, ortho units. So we've used it on every single unit in our hospital. There's no exemption. We don't classify it by unit, we classify it by patient. Is this going to help this specific patient? Yes or no? Do they meet the criteria and the policy? Yes or no? And we move forward that way. So we didn't focus on a particular unit.
Oh, perfect. And I love that you expanded it out to women's services, because I think that's sometimes a barrier. People don't realize that you can still use this technology in, postpartum, because my background is neonatal nursing. I think you have some pediatrics in your history, but I can't tell you how many times we would get called down and mom would go down shortly after giving birth, right? Because they get that hypovolemic hypertension type of thing. But can you talk about any kind of use cases that you've used, like kind of outside the normal med surge, like in your women's services, or if you have used it in pediatrics?
Not so much in women's services, but we had an individual case, this is one of my favorite stories, where we had a patient who did not speak English, and she didn't speak any of the languages that were already within AvaSure. So it was kind of hard to figure out what we could do for the patient to keep her safe, but also give her privacy. And they had an in-person sitter, and I was like, well, why don't we try a remote sitter? They said, well, we can't do that because the patient doesn't speak English. Okay, well, neither does the staff doesn't speak her language, so let's just try it. So what we did with her is we put the device in the room, and anytime she got up, we hit the stat alarm. And she knew when that alarm went off, she stopped and she waited for staff to come in. She had a very, very rare language, rare dialect. The family only spoke it. It was hard to get an interpreter. And it was just amazing to see how quickly she adapted to the device, knowing that, okay, if I do this motion to get up, they're going to hit that alarm, but somebody's going to come and I can get my bedside mode, or I can get that thing across the room, or my phone, or whatever the need is. So it worked out really, really well for her. And we were able to discharge her safely to her home.
Oh, that's an amazing use case. So let me ask you this then. So in that particular scenario, would the telesitter leave the alarm going, or just kind of do it to get her sit back down, and that was a trigger for your staff?
We always let the alarm go.
Okay.
Because if we stop that, then that's kind of educating staff in the wrong direction. So we always left the alarm on until somebody came in that room. But she quickly learned that somebody would be there if she made this motion. She would never get out of bed after that though. And if she heard that alarm, she'd stop and just wait for staff.
Oh, that's great. So you said at the beginning that when you started your program that you did not include suicide ideation patients. And now that you've been running for about 2 years, I think right around there, have you changed your mindset on that, or are you guys still not including them?
We are working currently on our policy and procedure on that. Our goal is to add the moderate suicide patients. So obviously not our high risk, the low risk don't need to be that closely monitored, just to kind of pull away from that population for having in-person sitter cases. It does help with their psyche, because they're there for suicide. They know why they're there. They don't want somebody watching over them. So this device will just further help their psychological development to be better, and it helps us have one less in-person sitter case. So that's our goal, to add the moderate.
Perfect. And for those of you watching today, we do have a session on suicide ideation coming up. So maybe you can take some valuable notes back with your team, Angel, and have some tidbits to share back with you guys once you start that journey of using it for SI patients. And just to be clear to people that are on the program and watching the program, you can monitor your low to moderate suicide ideation patients per the Joint Commission. You just have to make sure that it's included in your policy, and then you are using a nationally recognized tool to identify those patients. But it is, in all honesty, I think that's one of the scariest conversations for people to have in healthcare, because they're so worried about those patients having an event that you want to make sure that you keep them safe. But we're here to help you and help you build out that part of your program anytime you need. So we only have a handful of minutes left here. So I know you said you had that story about the stat alarm. Any other good catches you want to share with us today?
We actually had a monitor type. It was one of our fill-in monitor types for somebody who doesn't use us every day. And the patient just didn't look right. Didn't look like they were sleeping, just did not look right. So she hit the stat alarm, called the nursing supervisor over. The staff came in and the patient actually was total. The patient did survive, but with her attentiveness to that, the patient was asleep. And she just noticed that it doesn't look like he's sleeping. He looks a little, something else a little off. She was able to get staff there very quickly, because other than that, people would have just assumed the patient was asleep and we may have lost that patient.
Oh, goodness. That is a great catch. Before I let you go, we do have some more questions from our audience. Number one, who does your patient education with the nurses in regards to the tele staff?
So we have an education department that does do that. I do it myself, and of course the supervisors do it one-on-one as they round, and we have the monitor tech do it every time somebody comes in.
Perfect. Kind of like, I don't know if you heard the first session with Aurora. They were talking about doing handoff, shift handoff, whether it's the telesitter to telesitter or this clinical staff. Do you incorporate any kind of shift change handover, whether it's from the monitoring staff or the clinical staff to the monitor tech?
So, yeah. So a lot of times when the nurses go into affect their patients for the first time, they'll communicate with the monitor tech. And then we also have each monitor tech, they go through every single patient, what works, what doesn't work, what to watch for, things like that, just to make sure that we're watching the patient safely and catching those things early.
Okay. And then another question that we received is, how did you get your financial partners on board, especially in the midst of a pandemic, right? Tell everybody about how you were able to get this program up and running during a pandemic.
So we did a lot of data collection, and actually I have my numbers here, so if I'm looking down, that's why. And we kind of calculated it for 1 month of one person watching 12 patients 24 hours cost about $10,000 to $12,000. If you multiply that by 12, so watching 12 different people, 12 individuals, that's over $120,000. So it kind of speaks to itself, especially you have PPE and onboarding, turnover, other things that add to that. So it was an easy buy-in financially, because having 12 individuals that you're paying benefits to and onboarding and doing all this versus the one that can watch the 12, it kind of sealed the deal once you throw those numbers out there.
So did you have dedicated sitters within your pool, or did you pull from staffing?
We have dedicated sitters, but there are times that we do have to pull CNAs on the floor if we don't have enough sitters. And that's really what pushed this as well, because we were having so many sitter cases. We were being left without aides on the floor because they were having to sit. And it also sets your staff up for failure. If you have a sitter case that only needs occasional reminding, in the night shift, that person's going to fall asleep.
Right.
It sets them up for failure, and it sets the patient up for disaster. So that really helped us get the business case going. We had a letter from the med surge and the critical care director as well. We had a few staff write letters saying how it would improve staff satisfaction because they would have their aides back on the floor, and then sitters as well, because they're not sitting there trying to figure out what they're supposed to do while the patient sleeps and only moves once or twice in a 12-hour shift.
Yeah. So then did you reallocate then those folks that you had dedicated as sitters? I know, and to be clear, we know we can't eliminate all sitters, like that's just an impossibility. So did you reallocate them, or did you put them out onto the floor? What did you do with those FTEs?
So we were able to assist our emergency room a lot more. So
oh, nice.
They can go from having 5 people to no people to 20 people.
Right.
So we were able to allocate more staff to them and to make their ratios much more safe.
So you talked about staff satisfaction. Did you do any kind of surveys or feedback from the staff once you implemented the program, like any kind of metrics to show that maybe your response times were different now that you have your CNAs back on the floor, or nurses were more satisfied? Anything that you can share about that?
We have not, but our overall, great places to work. Castaneda Eval has done well as far as staff satisfaction with staffing ratios. So I kind of slide that into that area.
Yeah.
Hope that covers some of it.
Yeah. Well, of course, because if you think about realistically, when we're pulling our CNAs from the bedside, right? Some of the key components that I usually talk to organizations about is looking at if you can pull the data from your response times for nurse call, for instance, when the patient pushes the call bell button, if we're pulling staff, CNAs who are typically first line of defense in those kind of responses, and we don't have as many on the floor, right? What does it do to that response time? And then what does it do to your falls? Because patients, if they have to get up and they have to go to the bathroom, they're going to do it. They're not as patient as we'd like them to be. So it's really interesting if people watching the program are starting to think about this journey. These are some key metrics to think about, kind of like what Angel was talking about. Is it's not only your staff satisfaction, but your press Ganey or your patient satisfaction, and then also your response times. If you can capture that information from your nurse call solution, it really does help build that business case that you're talking about being able to respond quickly to those patients' needs. It really makes an impact, and it impacts your falls in a multitude of different ways.
Right. And that's something else we track too is falls on AvaSure. Does that contribute to our fall score? And actually, our fall score did decrease some as well after the implementation of AvaSure.
Oh, see, that's a win-win-win. You've got your staff back to the bedside, you got your nurses satisfied because they have support from their CNAs, and your falls were decreasing. And it's financial saving, right? So my last question to you, because I think I've held you long enough and I've badgered you with millions of questions, is do you have a dedicated team supporting your program, or do you rotate different nursing assistants in and out?
So we have 3 full-time, 3 part-time dedicated staff that are scheduled as monitor techs, and then we have additional labor pool positions where if we have a call out or vacation time, they're already trained, already ready to go and keep going.
Perfect. Well, Angel, thank you so much for your time today. You've been fantastic, and you have answered all my questions. I know I battered you with them, and I appreciate it, and keep up the good work. And you should get an award for running your program like what you give out. So that's amazing. Thank you very much.